Well, good evening and welcome to Senior Info. I think about what show I'm doing.
Where are you, Harry? You've got a long day today.
Yes, it's been a long day, but you keep busy. That's how you keep going.
That's right.
You have a reason to get up every morning.
I have a purpose.
Yes.
Energizer bunny.
You all know Kelly. Kelly's here at the first Thursday of every month.
Yes, I missed last month, so
Yes.
I'm sorry for that, but I am here, and hi, everybody.
Okay. And I'll let the other ladies introduce themselves.
Sure.
Why don't we start at this end?
Well, thank you for having me. My name's Patty Thibeault. I work for Notre Dame Healthcare. We are in Worcester on Plantation Street. We have a nursing home and assisted living on our campus, but I represent hospice and palliative care, which goes out into the community. We're in 44 different towns in the county of Central Mass, and we go to wherever you live.
Wasn't that a orphanage at one point?
No, it was a convent. Well, not a convent. I'm misspeaking. A convalescing home. So,
But it was a Notre Dame orphanage.
no. Well, there was a large building on Plantation Street.
I'm talking
100
way
years
back in
old.
the early part of the last century.
Yeah, 100 years. The building's been there 100 years, but it was our sisters that went there to convalesce when they were
Oh,
unwell.
Because you also, you still have nuns there.
We do, we do,
Yes.
yes,
Okay.
and I can speak to that.
Yeah, that's
And-
nice.
Hi, my name is Lee. I'm the mission director at Care Northbridge. And we have a long-term care unit and a short-term rehab.
which used to be Beaumont.
It used to be the old Beaumont, yes.
Yeah.
Lots of history in that building.
Yes, beautiful building.
It is.
It is beautiful. I'm Sharon. I also work at Advenia Care with Lee. We're here to discuss the assisted living as well as the long-term and the short-term and the dementia unit that we have there.
And then you were here last year.
Yes, I'm a repeat offender. I loved it so much, she called me, I'm like, I can do this, and brought in Patty. Lynne Alexandrowicz, I'm the Director of Business Development for a private home care agency called Accessible Home Care. We're what we're called a medical model, so we have RNs on staff, so we do a lot more than some of the other home care agencies that are in the area. So it's nice to have choices. But we're owned by an RN, and we have RNs on staff too, and we're located in, our offices are in Auburn, and we cover this geographical area.
And we're talking a situation that everyone's gonna face unless they do the alternative.
Which we don't recommend.
Right.
Right. But, so now we're talking home care is becoming a bigger factor today.
Mm-hmm.
Because a lot of people aren't at the point that they need to have 24-hour care, but they do need some,
Right, right.
especially if they're alone, right?
Mm-hmm. And I think what we just did a radio show with you about, there are two forms of home care. One is insurance driven, and it's usually Medicare covers it, and it's called Medicare Certified Home Care Agency, otherwise known as the VNA, Visiting Nurses Association, everybody knows that.
Yeah.
And then the other sector is private home care, which means insurance does not cover it. You pay privately for the care to come into your home. And your home can be living with a family member, can be living in a nursing home, could be living in assisted living. Wherever you are living is considered your home. So it could be a trailer park, it could be this, it could be living with
But even in
your
a
daughter.
nursing home, where
Yes.
they're 24-hour
So-
care already, right?
Sometimes when someone is in a memory unit and they really need a one-on-one and they've just been admitted to the nursing center, until they get really acclimated, the families like to have that adjustment period, and we can come in and do a one-on-one sitting. So,
And they do also come into the assisted livings.
right, and we work closely with Patty's group, well, all hospices, but Patty's group, which she represents at Notre Dame Hospice. I've had the opportunity to use hospice personally, and also obviously professionally, and it's just a wonderful program, and I wish more people would utilize it,
I think we
and
need
they
to
usually
talk
do
a
it
little
the
more
last
about it.
minute.
I think we
you
need
know,
to talk a little more
unfortunately.
about hospice.
Yeah, absolutely.
Sure. Yeah, we'll switch things up a bit because usually I go at the end because we we go through the
You go with the
order.
progression.
But I think hospice really relates to all of these ladies and what they bring to the table, because we go to wherever they live, whether that be an assisted living, independent living, whether that be a nursing home, an apartment. We have group home patients. We've gotten somebody a bed who was living in a tent behind, you know, a high rise. So, you know, we work very closely with UMass's palliative care program, because a lot of times, you know, they're seeing people that maybe don't have a lot of supports, and hospice will really bring in a lot of support. So I will say, right now especially, and we've spoken about this very often, insurance drives a lot of what we are able to access in healthcare. And we also have a palliative care program that is in the community, the same way that our hospice is in the community. And they like to switch around the word hospice and palliative care. It's an easier word to break to a family than the word hospice. Hospice can really be frightening for a lot of people. And palliative care sounds a little bit better. And
People
they use
hear hospice, they think they're coming in for
The end.
for the
right, and
5 hours.
there's that there's the myth versus the facts, you know? And so with palliative care, there really is not a lot of payer sources. So it sounds great, but it's really hard to have a successful palliative program because it doesn't really generate a lot of money. There aren't a lot of options. So when you hear the word palliative, look into it. Ask questions about what does what does that mean in your program? What does that mean in this program? Because they are all different. Because we're all trying to figure it out right now. Our particular program is consultative, so we're able to bill the insurance companies and Medicare and Medicaid directly. But it's like it's like having a podiatrist come to the house. It's like having, you know, any specialist. It's concierge sort of thing. But that really helps people to have conversations around what your goals are, your you know, and put plans in place. If this happens, then what? Let's have a plan A, a plan B, and a plan C, because that's what this whole thing is about, is people don't plan. We're just gonna wait and see what happens,
right.
and then
Wait for
we
crisis.
react, and we're in crisis, and then we don't have time to make quality decisions. So that program really helps people make quality decisions, and it's at an NP level. So they're having conversations that are including the cardiologist, the pulmonologist, the PCP, you know, they're having really high level, but they're having them at the kitchen table with the family so that the daughters understand what's really happening with mom or dad or both. The mom understands what's really happening with, you know, the husband and vice versa. So having these really in-depth conversations, but including the people that have to hear it. And when you're at the doctor's office and you've got 15 minutes, or you're at a case manager's, you know, coming in to see you at the hospital, you're not getting these in-depth conversations, and so you
Right.
fall through the cracks because you're like, we're fine, we'll just go home, and then we'll call 911 next time, and again and
And it
again.
repeats.
Yeah, and then you have hospice. So what happens, you know, some of these patients really are gonna benefit from hospice. They're really not, when they deep dive into what their goals are, it's not to go to chemotherapy or to, you know, be on these treatments and then have maybe 2 good days out of 7 because they're recovering and they're so sick. It's a hard decision to make. But then when they hear about it, and if they can hear about it before they're in crisis, hospice will come in. It's paid for through Medicare unless you are under 65. But then if you're on disability, Medicare will pick it up. We do take private insurances. And hospice is regulated, so there's these myths and the facts, you know. They think, well, if I sign my signature on a hospice form, I've just said they're going to die.
Right.
The fact of the matter is, that disease is happening. And what's gonna happen to you via the disease process is gonna be different per person, but it's gonna happen. That trajectory is that trajectory. So do you wanna do it with help, or do you wanna do it and stumble your way through it and maybe have a lot of regrets as the family, or, you know. So by having hospice involved, you actually can extend life, which people, it's a really hard concept to grasp, you know, that you can extend life. But, you know, some people, it's the medicine that's killing them, not the disease will eventually, yes, but
Right.
we've hastened it now with all of these treatments because they're so weak. They're susceptible now to pneumonia. They're susceptible to, you know, they're so weak. There's a fall risk,
Yes.
you know, and so on. So by having hospice in place, you will get more hands-on, eyes-on discussions with the medical directors. You know, you'll have more conversations around, do they really need to take all of this? What actually do they need?
Right.
We don't pump them up with pain meds till they're out of their minds, and that was also something that a lot of people back in the day thought hospice meant morphine, a hospital bed, and death. You know, and that's actually based in some reality, because back in the 70s when hospice was first established, was cancer patients needed morphine and such, but there was not a lot known about it. And so, yeah, they were really in a lot of pain, struggling, agitated. The hospice would then come in, they would give them the morphine, and yes, they would pass within 24, 48 hours. But that was because they were finally comfortable.
I was gonna say.
And they weren't, like, because your base of your brain, you know, you've got that caveman brain still that is fighting for your life. And when you're in pain, you are fighting for your, like, it is, you know, they call it intractable, I believe, or whatever. But that's a real thing. So when people say, well, you know, this is what happened to my uncle and this is what happened to my grandmother, yeah, probably did, but they don't know the reason behind it. And so now it's different. Like, if you can get in and you've got a 6-month diagnosis.
And that's a
one,
criteria. Could you go over what the
right,
criteria
so
are?
one, it's a 6-month diagnosis, so if this disease progresses in the way it has been, we think it's likely that they could pass within 6 months. Now, 6 months comes and you're not, we don't kick you off.
Right.
We stay with you, you know, the whole time, as long as this disease is progressing, we're there to go this journey with you. It is regulated through CMS, so it is not something where everybody just makes up what they have to do. However, it's regulated to what the bare minimum is. And some hospices will do the bare minimum. You know, we all get reimbursed the same amount of money no matter how much care we give or don't give, and how much, you know, we service and how much medication and all of that stuff. So it's interesting. Our particular hospice, we have, which I'll go through the ones that are regulated that you have to have. You have to have a medical director. You have to have RN, nurse case managers. You really have to have social work that now they can say, I don't need it or want it, that's fine. Home health aides that ours are certified in hospice specifically. Again, they could say, I don't need it or want it, but you have to offer it. You have bereavement, which stays with the family for 13 months after the passing of your loved one. And the reason the 13's in place is there's gonna be a first of everything.
Right.
You're gonna have your first everything without your loved one. And then we have spiritual coordinator. Now, and that's spiritual coordinator. You don't have to have a faith or a religion. It's really just like that life review at end of life where there's just some things, you know, and it may be something you don't want to do with your family. It's something you want to do with this person. You have to have volunteers. You have to have a certain amount of volunteers. It's based on your census. So based on how many patients you have to have a certain percentage of volunteers that can be available to your patients. And they're like companionship. They do a lot of just sitting and holding hands or watching your favorite show with you for people that are alone or in a nursing home and just really lonely, or just for families that someone needs a break. I'm gonna go take a
Respite,
shower.
yeah,
Could you
oh,
sit with
really.
them and watch Judge Judy? You know, I gotta get a shower in,
Right.
you know?
Right.
So it's, you know, things like that, or to play a card game or put a puzzle together. So those are requirements. Again, you don't have to take them as the patient, you know, you can just have a nurse, really. But these are offered to you. The amount of time that they spend with you, the amount of visits they make are dependent upon what your needs are. So we go definitely by the need of the patient. It could be as minimum of 2 visits by an RN, by a home health aide. It could be 5. If someone's really close to near end of life, we're there daily, without fail, over the weekend and everything, daily. We're on call 24/7, so you always have someone that you can call, and they will try to triage over the phone. If they cannot, they will go to the home. You know, it's like you need, and having that backup, because I know my father having cancer, he stayed with my sister, we all kind of pitched in, but that was a lot of burden on her shoulders. Do I give him more? Do I give him, like, you know, there was a lot of panic around that, and he had a lot of pain. It was pancreatic cancer. So being able to call someone and just have them give their blessing,
Yeah.
like you have it in the
okay.
home and you can do it, but you're just so racked with, am I doing the right thing? I'm not a nurse.
Right.
So it's really important, and it's such a small thing, it seems like, but it's such a huge piece of what caregivers are going through. And I don't think they understand the value of having that person that you can just pick up that phone, you know, and have someone be like, it's okay, try this, call me back in 15 minutes. Okay, try that, call me back in 10 minutes. And then by the end of those calls, they're resting peacefully.
Right.
I see the emails every single day in our communications, and so it just feels good to know that that person was able to then, okay, we did it, we got through another night, because the emergencies don't happen at 3 in the afternoon,
Right.
they happen at
No.
3 in the
3
morning.
in the morning, exactly. Right.
So what we do above and beyond that, though, is not that we also, the fact that we do more visits than the minimum, but we have music and massage therapy.
Right.
Very important.
And that is huge. That is not reimbursable. It is something that we choose to do because it's so very important, especially our dementia patients. Lynn can attest to some of the moments that you can bring to a family through music. And it's not just somebody, like my cousin plays guitar, they're gonna come sit bedside, right? This is a therapist who's
Music
got a
therapist.
degree and really understands that they're using this to bring down pain, maybe to calm agitation in a dementia patient, somebody, who's like kind of flailing a little bit, and you can bring down their heart
Anxiety.
rate. You can use music in so many ways. We also use it for legacy. We will write songs with people so that that family has a legacy. They will sing a song so that person has a legacy. So there's a lot.
You do
And then,
pet therapy too?
yeah, we have pet therapy, massage therapy, and the massage, again, you can't discount the enormity of touch. And not just, again, you have to understand, you have to be a therapist, because there's a difference between, like, if someone has dementia, you can't just touch that. You have to know, do they need to be touched? Do they want to be touched? Where am I gonna touch them? How am I gonna, and then you have to do it on their level. Where you have to meet them where they are and have them experience and then, see what they want. And then you have other people that are like, yeah, sign me up. They've got a lot of pain, and it really kind of like, they can work on it, the pain. It could be at something, somebody who's got contractures, it can really, help with their hands and arthritis and things like that. So that's hospice in a nutshell. I will say, though, that myth-fact thing, it's very difficult. The other reason people have a very difficult time signing loved ones onto hospice is you have to agree you're not gonna call 911, you're gonna call us.
It's the hard part, yeah.
I flipped out when I first heard that with my dad, because this is way before I was in hospice, and I'm like, what,
It's
And
scary.
It is.
the hospice didn't
People
explain
have
it
been
to me,
trained to call
but I knew
911.
someone in hospice, as a matter of fact, I work for her now, and she was lovely and was able to explain to me, think about the practicality of this. So your dad's dying of this cancer, he's in a tremendous amount of pain, he only has this much, he has a heart attack. They perform CPR to bring him back. Now they've broken all of his ribs, he's frail, he's 83, he's in already a lot of pain. Now he's on life support because it didn't really work, but he's still with us. Now you gotta make a different decision. Yeah, okay, he comes back, to what? More pain and a pancreatic cancer diagnosis. But as a daughter, you're not thinking, as a son, a mother, a husband, a wife, you're not thinking in practical terms.
Right.
You're
Right.
thinking knee jerk, what? If something happens, now, if they fall and break an ankle, we don't want them in pain, send them to the hospital. They gotta get an x-ray, and then we have to decide, is it practical to do something with that, or is it not practical, and what's the plan?
Right.
We've had people come off of hospice to get surgery, go to rehab, and then they come back on hospice.
Yeah.
It can
Right.
happen,
Yes.
it depends
Yeah.
on what's happening in their disease. The other thing is IV liquids and feeding. As caretakers, our job is to make someone get better. So we all know when you're sick, you have to hydrate and you have to have some soup to get better, and you have to eat to get your strength back, and you have to take a shower so you can feel better, and you have to get up out of bed so you can, those are all completely opposite to what the hospice philosophy is if that person is no longer benefiting from that. So IV fluids, if you are at end of life and you are no longer able to absorb those fluids, they're actually gonna pool. And it can hasten death. If you feed someone and their intestines are not working, that's laying in their belly and turning into toxins. Doesn't feel good. And, if they're exhausted and their disease has progressed to the point where it's a bed bath to keep, because you want them clean and dignified, and, we don't want them to not be, but getting up and taking a shower,
Right.
at some point, but we have to let that happen, because what happens, the brain and the body know what to do. It's in our DNA. We know what to do. But the outside world, we don't talk about it. We don't want to accept it. We don't want to see it for what it is. And it's because it's very difficult because we've not been trained to let go. And so it's hard to sort of let nature do what it's supposed to do. It
Right.
sets you up. Your body stops being able to take on food and digest it. It stops being able to absorb fluids. It stops being, it's shutting down.
Right,
And so that's what nature does. But to have a hospice team to be able to educate you way before you get to that place, right? They start
Right.
preparing you. This is what, if you see this, these are some of the things. And like, it's just so nice to be like educated. Like, mom's grimacing, what does that mean? Well, she's probably having some pain, but she's not able to express where
Right.
or how. So now let's go through the list. There's those things. It's just having experts that they do this for a living. You do
Right.
not. And you're expected
Right.
somehow to just, they send you home from the hospital, oh, mom needs hospice, she's got this X disease, there's nothing else we can do, and take her home, and you're like, and that's where, like, Lynne's company would come into play, because they think they can do meds 24/7, but holy cow.
Right.
Oh,
Our
You
son
know,
thinks he can help
holy
his
cow.
mother in the bathroom.
Right, a shower, and we'll do showers and things like that, and, but I think a lot of times it's just the sheer exhaustion.
Right.
So you might need a private pay, it could be just 4 hours maybe,
Right,
just to,
just even
so you
for
can take a
respite,
nap,
right. We always have the families that are working and they're trying to take care of their loved one, and they've got young kids and what have you, and they go, oh, I can do the 11 p.m. to 7 a.m. and they can't. You can't function the next
Right.
day. So our aides come in, and our aides have gone through extensive training with your hospice division, and they can also do the meds. And we're a medical model, so we have RNs on staff. So our nurses speaking to their nurses and constantly updating, coordinating this, this med change. Okay, now we know.
Yeah.
So
And sometimes they need a nursing home, like,
right, they go into a
sometimes
nursing
we
center.
get to a place where it's no longer safe, it's no
You're
longer,
home,
even the
right.
families, like, we've bitten off more than we can chew. The social workers will help them so the burden is not on them. The social worker will contact the nursing homes in the area to find out who has beds. Then they're gonna work, like, what insurance, do we need Medicaid, do we need, like, what do we need to have in place to make this happen? And or, do they just need respite for a week or two, and with this nursing home, take this patient for
Right.
5 days, it's covered in your hospice benefit, and you just can have that 5-day break, we pay, through the Medicare benefit, we will pay the facility. They'll have that 24/7 care, and then we can make a decision after that. Do we wanna stay, or do we wanna go back home?
Right.
What do we wanna do?
I think it's a
You
good
know.
segue into talking
That- I-
about
yeah, I
nursing
would.
homes. Yeah.
So-
And it is November is National Hospice Month, so, we thank you for
This is
all
such a
your
good
staff and
program.
how,
It is.
Yeah.
the work that they do with the
Yeah,
families
it's
and the
gotten
patients.
better with,
Right.
when I first started, literally, they were still saying death angels. Now, there's a
Right.
few here and there. Generationally,
It's
we
changed.
have now hospitals that can no longer, have people in the hospital for days on end,
Right.
weeks on end, pass away in the hospital.
Right.
So there is more education around why it's so important to, like, if we can't treat you anymore, you really need to do this next thing.
Right.
right.
Right, and
so-
again, going into a nursing center, if you wanna talk about the difference between short-term and
Yeah,
long-term.
definitely. So, short-term rehab, when you're going to a hospital setting, just, let's say a case manager comes up to you, say you need placement to go to a rehab, nursing home, any of that type. Think about your options, think about what you're gonna do next, think about where you would like to go. Sometimes it's a 30-mile radius from home, sometimes it's 40 miles for your family members. So it's a good place to start, touring facilities, figuring out where you would, your goals is, if that facility has physical therapy, speech, what your diagnosis is, so what works best for you. Once you figure that down, figure out what the insurance will take for that rehab, if they take Fallon, they take Blue Cross Blue Shield, Tufts, any of that, so that's a great start. For us, an average stay was about 20 to 24 days of average stay. Some insurances, depending on Medicare, there's certain copays. Medicare has a first 1 to 20 days, that's 0 copay, but on day 21, there is a copay of $209.50.
And that changes yearly.
It does,
because
it does.
of- right.
It has gone up throughout the years. It's something to think about if you can afford those copays. If you can't, you could discuss getting a secondary insurance. Mass Health does cover those copays, or you can get supplemental plans as well.
Great. And the long-term care is someone's actually living,
Correct.
moving in, living, the nursing
Living
home
in.
becomes their home. And, they receive all the benefits of having 24/7 care within a home, within a nursing setting. Right.
And they
And
can go
memory
from
care?
the rehab. We also
Yes.
have a memory care.
Yes, we have memory here as
Yeah.
well.
What does that look like for you
So
guys?
we have a set dementia unit. It's a certain amount of beds. That unit is really geared towards Parkinson's, dementia, any types of dementia. We can, as long as they have the diagnosis, they can be in that unit. Activities are much geared towards the dementia. We have activities for it. We have, foods daily, and just rooms that's really geared for that diagnosis to help
The
them.
nurses in some of the activities people are dementia certified practitioners, taking the courses online. To do that, the activities in the dementia unit are 8A to 8P, so it's a full day
Wow.
of keeping everybody busy with multiple people working at the same time. And unlike the rest of the rooms where people might stay in their room all day, if you go down to our first floor to our nice dementia unit, everybody's pretty much in the same room.
Yes.
They eat their meals out there. They do activities out there. They watch television. They sing. They have a pub down there. Like they do a lot of fun things to make them feel like they're at home.
Which is so
And the
important.
diagnosis has to be in place so that everyone down there, and you have to be fit also. And it's a small unit,
It is.
and so you can't have somebody who's not going to fit into the community.
Right. And you also have an
Yeah.
assisted living on the property
And
too,
we have an
right?
assisted living, and we have 26 apartments. We have from studios to 1 bedrooms. It's mostly single people living in each room, but we do have married couples that will come in and be there for a while, which is nice because sometimes they come because maybe my husband's not doing as well as I am, so we're going to go see how things go. But then he needs to go to the long term. But I can just walk over every day, and I can see him.
Visit.
And I can have my meals on his floor, and then I can go back to my place, and I can actually relax because taking care of it home
Which is important.
was too much.
Yeah.
Right.
It is a very nice option.
Right.
We do respite at both,
Yes, we do.
both
Which is
places,
nice.
at the skilled nursing and at the assisted living.
It's kind of like testing the waters to see.
It is,
and,
or caregivers get
Right.
burnt out.
Right.
Like you think you can do it forever without calling people for
can't.
help
You
because
can't.
way.
sometimes
And
you think it's so expensive, but 24/7
Right.
is a lot harder.
And then
because
you
it's
end up in the hospital.
Physical. It's
and you're the
emotional.
caretaker.
It's difficult. So we do respite in both, which is nice.
Facilities.
Lee can help with all that. She's admissions.
Yes.
And
And we recommend touring, like,
Yes.
go in and tour. Don't wait till your loved one or yourself is in the hospital and the discharge planner is saying, okay, you're being discharged in 24 hours. What are your plans? Where are you going to go? So, we recommend choose three assisted livings to tour, 3 nursing centers to tour. There's a rating system for the nursing homes, and it's a star rating. And you can look online for MassGov, and it lists every nursing home. It's like 300 something left in the state now. And the star rating goes from 1 to 5, 5 being the best, 1 being the worst. So look at the star ratings, and there's always a survey book in the lobby when you walk into a nursing center, and you can see how they did. You're surveyed. They come in unannounced with a group, and they survey everything from maintenance to food to med passes to this to that. So
to ceiling tiles, to temperature,
Yeah,
to
yes,
food
yes.
temperature, to hand sanitizer.
It's always a testy time when they're in the building.
Word of
but-
mouth too. There's
Yeah.
nothing wrong with asking the
Exactly.
neighbors
Right,
and
correct.
Right.
our
And-
communities are pretty good
Right.
source of information.
And like you had said, I think it might have just been when we were on radio, but advocate for yourself. Because when
Absolutely.
the hospital says, we're sending mom to here,
Yes.
and you're like, but
No.
dad lives in this town.
Right.
I
Right.
maybe live here, but dad's going to visit her every day, and he's not going to drive.
Exactly.
He's not going through Kelly Square to get
Right.
there. I'm sorry.
Oh, gosh.
He's never left Northbridge.
Right.
So, there are those people and that's a
Yes.
huge
It's a
factor
valid
that you have
point.
to think into,
Very important to advocate and, again.
and see them for yourselves because
Right.
Yes.
even if you have to do a call and say, hey, can we do a virtual? Can you show me a room? Can you do this
Right.
because I'm out of state? I mean,
Makes
technology
a
is
big
wonderful.
difference, right.
But you do have to see it for yourself. You do have to make
Mm-hmm.
the decisions
Right.
ahead, and you do have to advocate.
And pre-plan, you know, I always use the analogy, if someone's going on vacation, you plan. I'm gonna, you know, either drive to a vacation, I'm taking a train, a plane, I'm gonna stay at this hotel. People put all that work into planning a vacation. They don't plan for if something's gonna happen in their life, we're all aging. We're born, we live, we die. Those are, you know, your three options in life, right? But plan for it, you know, and it's always like, oh, mom's never gonna fall. Really? Because I fall. Everyone falls, right? So mom can fall, you know. So again, be advocates, plan, put things in place, you know, if you have the means financially, meet with an elder law specialist, put things in place. Let your family, we were mentioning on the radio station with, the holidays upon us, you know, Thanksgiving, a lot of times you're doing FaceTime with your mom or whatever, you come home, you know, for the holiday, and all of a sudden you realize, like, ooh, this is not what I was seeing on FaceTime.
I've never seen her walk across the kitchen
Right,
floor.
right. So
She
make,
didn't walk like that last
make a
time.
decision and, you know, have that conversation at the holidays with, what are your plans? What do you want to do, mom or dad, if things happen? What are your choices? You know, and have that in writing, and have, if you have siblings, you know, the family dynamics are always very interesting to deal with. But have that in writing, because, you know, your sister in New York says one thing, your brother in, you know, South Carolina says another. You're living here. You might not be the healthcare proxy, so you're really not making the decisions, but the brother in South Carolina is. So you really need to all work your, you know, your feelings out, be on the same page. And, you know, we deal with the family dynamics every day. In crisis situation, we all get those calls, you know, my mom's being discharged, I don't know what to do, you know,
Right.
yeah.
Yeah.
So, and, you know, the discharge planners at the nursing home, at the hospital work with you. We're all resources, so, you know, we say, if you have any questions, you can call us at any time. We work with everybody, you know, we don't view it as competition, we work with everybody, we recommend places, we recommend companies. You know, again, it's the outcomes is so important for your loved one and yourself.
Absolutely.
Central Mass is definitely a very tight-knit.
It is. It is.
You know, I've worked in a lot of different markets under a lot of different, you know, phases through my life. And when I came here, I was like, I thought this was the second biggest city, but it felt like I was in a town. Like every area, it's like, there's like neighborhood, like everybody kind of knows.
Right.
When you walked in, everyone's like, oh, I know you, I know this, I know that.
Kelly, we used to know each other
You
like
know,
20
but
years ago,
there's
right?
always those
You know?
Use that to your benefit,
Well, I
because it's
think
not
definitely.
like that in a lot of places,
Well, I think
and I
healthcare in
love
Massachusetts,
that.
like, we have the best hospitals, we
We
have
do.
the best
Elder
medical
services.
schools. We
You've
have
got elder
those.
services
So when you
and-
have the
and-
community services that
Right.
work together, I mean, we saw each other and we were like, how do I
I
know
know,
you?
I'm like, we're going
and we've
back,
been
like
to
we know
shows
each
before,
other.
like we've
Right.
met each other certain places.
Exactly.
It's just okay
And-
to know, like, it's
Yeah.
okay,
You
just
know who to
because you're
call.
looking at the information doesn't mean it's gonna happen, just
Right.
like, you know, you really don't have control, like, total control,
No.
so it's
right.
okay.
Right, and again, we were talking about home care, and, you know, home care has been established for years, and people say, oh, the V&A, and it's gonna be all paid for. Well, you know, it pays, certain insurances pay for a certain percentage of, you know, nursing, aides, whatever, that are gonna come to your house. Maybe you had a stroke, so you need speech therapy, you need occupational therapy. And it's not for, you know, 6 months. I mean, it's all based on insurance driven and what your diagnosis is. And then, you know, it has to be signed off by a physician if it's a Medicare certified home care agency. And you can't, if you're starting to feel better and your daughter says, hey, let's go to blah, blah, blah for lunch. You can't leave your house if you're under a Medicare certified home care
Right.
agency, unless you go to the physicians, but you can't just go shopping at the mall or whatever. Private pay is what it is. It's not paid for by insurance. You pay privately for that care. We can come in and do a live-in aid, which means they physically move into your house, take care of you 24/7. Sometimes it's needed when someone first gets home from the hospital and they need 24/7 care. So that means 2 shifts of 12 hours each. An aide comes in, is there at the night, is up all night long in case you get up in the middle of the night or whatever. We do one-on-ones. You know, we work with assisted livings. We work closely with the hospice companies. We work closely with the nursing homes also. So, you know, if people are trying to spend down and they're over that asset and they're trying to spend down, we can go in and our aid can be there, and that all those invoices go towards your spend down for your Mass Health application.
Right.
So, a lot of options. It's nice. We always say, it's nice that we don't live in the Midwest and we have to drive 3 hours to get to a specialist. We have great, level 1 trauma centers and hospitals, 20 minutes away. So we are really blessed that we have so many options in this geographical area. And I think we just tell people, educate yourself. And, thank God for Google, right? Because everything's Dr. Google now. But you can Google and look at things and be educated and make rational decisions versus irrational decisions,
Right.
which we've all seen happen.
Oh,
Well, and
yeah.
having a
Yes.
few options, so you have plan A, B, and C. Plan A is we want private pay. Plan B, we gotta do mass health.
Right.
Plan C, she falls, now we have rehab, so you just kind of wanna play out a few different scenarios. And kind of know where where's my go-to questions gonna
Right.
go, like, what am I gonna ask? Because most people, the biggest hurdle in the hospital setting is knowing what to even ask.
That's great.
Because you don't know what you don't know. It's not what you do for a living, and all of a sudden you're expected to know what to ask. And this is your first rodeo, right? You've
Right.
never done it. And we have great hospitals and all that, but they're very busy.
Right, right. And there's certain generations, the people that are in their 90s now, whatever a doctor said when they were growing up and seeing physicians at that time, that was God, so to speak. They never questioned anything. Well, now, yes, you can question and say, well, I don't think I really want this test, or I'd like to have this test, or, again,
They're also the
advocate.
generation of their life is so private.
Right.
Yes.
You don't want
That you may
anybody-
not have
Yes.
ever even known that your grandmother had cancer because she didn't tell a single soul.
Right.
Right.
And then you go in for your history, and then your mother's like, no, your grandmother had cancer too.
Yeah.
And I'm like,
Right.
You're
when I
like,
was
"What?"
alive?
Yes.
Because that's a whole different generation.
You're right.
Which
Yes.
you must see that, though, at the senior center. But
definitely.
you guys have become
But I
good
see
advocates.
it evolving too.
Correct,
As-
which is nice.
Yes, it is. Yes.
Right. It's a
Um,
proud generation.
Yeah.
It
They
is.
did for themselves, and personally, when my mom was diagnosed with dementia, and as I said, the average person, dementia to death, it can be 20 years. And my father said, we'll never put her in a nursing center. That's
Never say
what they may
never.
teach other, but at the same time, she needs more care than, home care. And that point in time, we had to make the decision. So, but that generation is so hard. And I can remember when we were having my company come in home care wise, my father's like, I don't want anybody coming into my house. I have my mom, was, livid at times, and she'd be like, oh, I haven't dusted. I don't want anybody in my house. I'm like, okay, that's not a reasoning, but, but again, it's, that generation is different, and they did for themselves. They didn't need care.
Right.
But again, it's nice to see that it's changing.
Definitely,
And people are
yes.
saying, okay, no, there's options out there. I need to look at them. I need to educate myself. I need to make decisions,
And I think senior centers too
Oh,
have a
they're-
whole different meaning now than they did to that generation.
Sure do.
Like my grandfather wouldn't go there, and finally we were like, Grandpa, just go.
Just try it.
And I went to the club. Can you believe I got a coffee and a Danish for 85 cents at the club? And I'm like,
Best deal in
the
town.
club?
But you get a lot of people, I'm not going there because it's all old people.
Yeah.
I'm not gonna
not
go with all
old
those
enough.
old people.
Yeah.
Well,
And that's like an 85-year-old saying that, right?
Right,
Oh,
I'm
God,
not
no,
old
there's old
enough.
people
Well, that was
there.
my grandfather, and he's like, and
That's
you wouldn't
the truth.
believe it. I had coffee with a gentleman who's actually Bobby's friend, who's his son.
Exactly. The connection.
But they had
Yeah.
the same name. He was a junior and a senior, so it's like, this is how he met him.
Yeah.
Yes, Grandpa, you're 25 years older than him, but
Right.
he doesn't feel bad going there.
No.
And you have to
Right.
call the club or you won't walk in.
That's right.
But you offer tons of resources.
Yes.
And
You do the Meals on Wheels too, right? Do you
So
do-
the
or
Tri-Valley
does
does
it?
have
Okay.
a nutrition coordinator that's stationed out of our center. And so we do the Meals on Wheels program. We were doing a congregate lunch on our own that we've put on hold for a little bit, just until the first of the year. And then we hope to bring that back but eventually in our new facility.
It's exciting. Yay.
Thank
We're very
you.
happy for
Yes,
you.
we're very excited about that. We, the plan will include a commercial kitchen where we hope to have our own chef and culinary team. That sounds so wonderful, but
someone to make sandwiches.
someone to be there to make something that's going to be tasty. And so we're really looking forward.
great.
to
That's
that.
exciting
news,
Yes, yes.
How many
happy for you.
elders are in the Northbridge, Whitensville?
So
community?
according to the 2020 census, which
Mm-hmm.
is what we work off of for all of our funding and grants and whatnot, it's 4,066.
Wow.
But we all know that it's much
Right.
larger than
Correct.
that. And as we
Well,
continue
since
to,
then, we had over 60, over 55,
I'm just gonna say, we
Project
keep
come in.
building.
Correct.
so
And we
that,
have more
and we
coming.
have another one on the books coming up.
Oh, you do?
55
Yes.
retirement communities
Yes.
coming in,
55 and
right,
over.
yeah.
Yeah.
Wow.
In Whitensville? Or,
Yes.
oh,
Yes.
Oh, in Linwood.
in Linwood,
Mhm.
okay.
Which is part of Whitensville and
Right.
Northbridge,
Yes.
right?
It's all,
Yeah.
they're all
Villages with it.
villages.
Yeah.
Right.
Yeah.
So, you know, it's gonna make a big difference right there. But the one that they recently developed, a lot of those people do come down to the
They
senior
do,
center.
because in their neighborhood, as we call it, it's the
Yes.
Stonehill condominiums, the developer chose not to build a community room. So we are their community room.
That's interesting.
Which is interesting, so you better bet they were very excited to have a new facility as well,
I'm
and
sure.
really brought in a strong vote for that,
That's
so.
great.
That's good
Yeah.
though, because it serves everybody.
It does,
It
yeah.
serves
really is.
everybody.
Yeah,
Yeah.
it's so important, so. But,
Because we did, that was another conversation we had on radio, was socialization with
Oh,
our
that's
elders.
huge.
So
Right,
important.
It's so important, whether they're
isolation.
going to the senior center, whether they're moving in with my assisted living or her skilled nursing
Yes.
center, or if they're not doing well and hospice comes in.
Yeah.
in home care,
Or
we go
home
in and
care
we
is
say,
going in.
you know, such isolation, and we were saying during, you know, when COVID was peaking, you know, we saw so many, so sad stories of isolation. And,
Yes,
you know, and the hoarding, you go into the houses and the hoarding that's gone on,
yes,
and, yeah.
yeah.
Yeah, you don't see it from the outside, when you get in, you think, oh my
And they're
God.
saying,
Yeah.
oh boy, we
Yeah.
have some work to
I
do
know.
here, yeah.
So we all work in unison and concert with each other. Again, we're all resources. So, you know, I represent accessible home care, but I also know people who work for VNA, so I can make a phone call and say, make a suggestion that this family wants to talk with you. Hospice, nursing centers, assisted livings, you know, it's very important that we all work in concert with each other.
And you know what I didn't mention, and I'm thinking about this, especially with the senior centers, we're doing a lot of work around with our veteran population.
Yes, yes.
I
Which
just
next
did a
week,
presentation for one of my groups, Lynne was at the presentation, just about the sheer quantity of service members and veterans that are going to be aging, you know, coming into this arena. And they're dealing not just with dementia or Parkinson's, but they also have PTSD, they have brain injuries, and, you know, so they're not gonna fall into a very specific box. And educating is really important. And I know like a lot of the senior centers, they have really great veteran programs, or they'll have like somebody that will at least
Great.
come in once a month to work with them on different things.
Right.
But yeah, and the program we have is hospice specific. It is a partnership from the Hospice Federation with the VA.
Nice.
And you have to hit certain marks to earn your stars. We're waiting for our 4th star to get
That's
delivered.
exciting,
Yeah, it's
right.
really exciting. We work with Veterans Inc., we work with our senior centers, we work with local ombudsmen, and we get we have volunteers that are veterans, because we really try hard to do veteran-to-veteran volunteering. Because you know they don't want to chit-chat with,
Right.
No.
you know, they're not talking to their wife about what they
No.
went through.
Exactly.
And so having another veteran, even if it was a different, like, branch, a
Yeah.
different time, a different element,
The
there's that
experiences still,
camaraderie.
right,
They
they're
definitely have a
similar.
brotherhood and a sisterhood, because we also have a lot of our sisters, you know, we're nurses.
Right.
We have a lot of nurses that
Nurses.
were in the military, that are now coming of age, because, you know, Vietnam, it was,
Well,
you
you have a
know.
lot of women in the military now who aren't in nursing positions, in regular combat
Oh,
positions.
yeah, well,
Right.
that's, and so that's a transition that will happen, and that'll be
Right,
something
right.
too.
And that'll
Because
be
now they're
accurate.
gonna come in with the brain injury and the PTSD.
Of course.
Well, then, and the nurses, they do have PTSD.
Correct.
Um,
How could they not?
But we are seeing it more and more as women did progress into the military, and they're the ones that are, you know, gonna be coming, and we're not necessarily paying attention to that as lay people, because they may be served, like Lynn's mom, you know?
Yeah, my mom was a lieutenant in the
That's
Army. She was
awesome.
a surgical nurse, RN. And my dad was a medic 2 times, and he was a sergeant. So, you know, again, what they saw during wartime.
Oh,
you
yeah.
know. And I laugh, my mom passed away 2.5 years ago, but when she was like 85 years old, and she said, "Do you think I should renew my nursing license?" I said, "I don't think you'll need it, Mom, but if you want, we'll do it."
Well, and Lynne could talk to you a little bit about one of the programs. By doing this program, we all have to, our entire staff has to be educated. We have to do so much community work, so much education. There's a lot that goes into it. But Lynne experienced one of the things that we do.
Right, the pinning, which is
yes.
so precious, really is.
Yeah. We'll go bedside if they're in a nursing home, or we've had people throw huge parties at the house, and everybody comes, you know. And what we do is we thank you for your service, we honor your service, your loved one will pin you, and we have a certificate, and there's cake, and our whole staff is there, and,
really
you know, the
nice.
family's there, and the pride, I mean, you'll have someone who maybe hasn't, you know, they're really suffering, they're, you know, not doing well. Boy, that posture
right
comes up, and there is a proudness, and they usually have their cap on, and, you know, and if they're
It's very
military
precious.
families, it's so appreciated from the family,
Right.
because they get to feel that pride too. We have a lot of families that,
Right.
it's generational.
Well, I think what people don't
Veterans
understand
Day
with
is next week.
hospice
Yes, it is.
is
Yeah.
that hospice
Tuesday.
isn't just for the client. It's not just for the patient.
Yeah.
It's for the family, and the family can just, the support that hospice
Right.
gives.
Yeah, and that's what I mean about having that,
It's
like, that
so
team of experts
nice.
that have your back.
Yes.
Right.
And can suggest things. You don't know what questions to ask. You don't know what you could possibly do for that. Like, what is life review? And so they can give you options. You know, who was that person? Were they a school teacher, or was it a fireman? So they're going to be very different end of life sort of things that we want to touch on or tackle. So, you know, and that can change how you all, I don't want to say survive it, but once
The grieving process.
once you
Accept
get
it.
you know, once it
But you
happens, you know,
accept it and you are part of it.
there's a lot more. Well, it's funny, our bereavement program, when we do bereavement, we don't get a ton of people coming in, but I do a lot of grief to grief, peer to peer, I should say peer to peer grief support programs in 4 different senior centers right now. And that's where we get all the people, because they didn't have the benefit of hospice. Maybe it was sudden loss, and maybe it wasn't, but they just didn't have that
grieving
benefit. So
process,
there's
right.
regrets, there's questions, there's acknowledgement, and they just need validation around that.
Right.
And we don't see that as much in our own program, because we're so,
Involved.
you know, we're prepping you, we're trying to get all the things in place, you know, so it's, there could be, you'd be surprised how many, like, really happy moments and fun moments and funny stories. Like, it can actually be a really nice thing, but I think we just, our society has just taught us to, like, take every medicine we can take until we can't take it anymore, or, you know, get every operation you can get, and quality of life isn't always,
Right.
No.
I
a
think what's good
discussion.
now too in med school, they're actually speaking, there's courses on hospice for the med students, where, you know, physicians, you know, their
Exactly.
oath is to heal, right? So they're not thinking, we're gonna give you every pill, every operation to keep you alive, versus having that education now when they're med students to say, okay, there are other options out there, not only for the client, the patient, but their family, and how their
we
family's
even have,
involved.
we have fellows that will come and stay with, and do, you know, work with us.
Grounding
We
or
have
whatever.
DNP students, which is doctor, nurse practitioner, and they will come and work with us for, like, as a case study for like a year, to do their
fantastic.
thesis,
Yeah.
their end of year. And, you know, it's usually based on hospice disease and outcomes and goals and things like that. And then we've had that happen for 3 years in a row. And it's
wonderful.
really
That is cool.
amazing to have it seen when you have somebody at that level in school presenting on hospice or goals and outcomes of palliative care.
Right, and
It is changing.
Our age just went through an extensive program with training with your hospice division. So because we're a medical model, our nurse to nurse and our aides can help administer the, you know, the medications. So because,
nice.
which is because we're a medical model.
Right.
So very different, because again, families are saying, oh, I can do that, and then they can't.
Right.
you
Well,
know.
and, you know, and it's a tricky thing. There needs to be really good communication on both sides of that. And so it behooves us to train staffs of agencies that we work with, so that there are good goals and outcomes, because we've now recommended this company. We don't
Right.
want anything bad to happen,
Right.
so it's good
Yeah,
for us to do that.
And our nurses are in constant contact, because again, you know, when things change, their meds change, so we need to know, you know, that changed from 24 hours ago. So we're in constant contact, which is
And
Yeah,
nice.
the other one's calling it 24/7,
Right.
you know, should I up the dose or what, yeah,
Right.
yeah.
And then on the other side, in the nursing home, when we have somebody on hospice, our nurses work with them, and the
Right.
hospice nurses come in, they call them for things, because
It's a great.
we share the
collaboration.
patient,
do.
but, you know, some things supersede.
Our cap is on differently. My
Correct.
my director always said, like, you know, we take the cap and switch it backwards,
Right.
right? Because our goal isn't, we're not fixing it at this point.
Correct.
So, and your nurses are trained and your aides are trained to feed them and shower, you know, to make sure they stay healthy and active. And now we're coming in and saying, if they don't wanna eat, don't make them eat,
Right.
right? If they don't wanna drink, don't make them drink, like,
But I feel like it's so much more
But
accepted
let's-
now that they can work as teams.
yeah, and
they,
then the
like,
nurse can come back, oh, well, no,
call.
that's just her being stubborn, and then, and these are the
Right.
discussions you can have with family and you're considered family, your staff is their family,
Very
let's
much.
face it.
And I think when your aides go into a nursing center too, you know, because your aides have so many patients, that it's a little more help with having an aide from, you know, be it your hospice company or other hospice companies to come
Oh,
in,
sure.
and
There's,
nurses, yeah.
there's you see a lot of respect when it happens.
Yeah.
You see
It's a
the
nice
nursing
flow.
staff on ours, call the
Yes.
nursing staff on yours. We see your people come in every day to see different people from different hospice
And even
agencies.
helping communicate that education to the family, because again, your staff is seeing them every day, they're seeing the decline. The family may not be aware, and so our nurse can like, kind of like, you know,
Help.
report out. And then that way, when they do come to visit, it's not, what's happened, you know?
But it just shows like none of us are really in competition.
Right.
Because
Yeah,
we
we're
all need each other.
resources, right.
So that the
Oh, there's plenty to go
46
around.
Yeah.
There are plenty of
Yeah.
people
Somewhere
that
to
need
go.
help, right?
There sure
Yeah.
Yes.
have somewhere
I
to
couldn't
go.
take them all, none of us could take
No.
every
And
And
single
the
person
other
that
my
needs
company
us.
always says there's enough
There's
clients
enough
and
to go
patients
around.
for everyone
Yes.
out there, which is
Plenty.
true, yeah.
Yes.
And sometimes they don't need certain care, they need something else. So it is good to have.
But it is a collaboration,
Right.
so whether
Exactly.
we're working with
Definitely.
assisted living, nursing home, even rehab, our palliative care
Yes.
team
Mhm.
for discharge planning,
Definitely correct.
right?
Yes.
To make sure that they not re-hospitalized, that they really do, because, oh, no, it's gonna be great, we're gonna go home, it's a, you know?
And maybe they don't need hospice.
And they live
but
on
they're
a
going
three-decker
home,
on the third
But
floor.
they need you. They need someone to come
Right.
in and still help them because
Just to
their
bridge
stays
that
in,
gap from
and then
here
they
to
just
there,
need to get a little
no.
bit more, and the
Yeah.
family can't be there. So,
Right.
and then we
Yes.
can set them up to take that bus right
Exactly.
over to you, and we know they're safe all day,
Exactly.
Monday through
And
Friday.
I think too, you know, generations, families stayed in the town, right? And now the kids are, you know, they graduate from college, they're like, I'm leaving, you know, Northbridge, I'm leaving Whitensville or Linwood, I'm going to the West Coast or whatever. So you don't have that family unit of helping take care. So that's where home care comes in. That's where assisted living, you know, hospice comes in, that we are resources we can help. And again, we just stress, really advocate for your loved one, advocate for yourself, be it in a nursing setting, hospital setting, ask questions.
And it's okay to put the brakes on if your loved one is in the hospital and you're completely overwhelmed and you really don't know, is it safe to come home?
Right.
Should I go? Like, you're trying to make these decisions. You can say, you know what? It's not safe in 24 hours. Like,
right.
I can make it safe in 48 hours or something,
just
but
need
I
that
need to line
extra
up
day.
private pay. I need to get my cousins in. I need to get, or I need to you know, it's just, it's okay, because the system is very difficult. They need the beds. So you can't say, oh, I can't do this for a week and a half, that's not gonna fly,
Because
but you
they're
can
not
say,
gonna care.
listen, I need more than 24 hours,
Right.
or this won't be safe.
Right.
And that's a really good word to use around anything out in
Yes.
healthcare, safety.
Right.
Use the word
Yes.
safety, it's a
Yes.
trigger
And
warning.
you
Yes.
can appeal to, again, it's so much, everything's insurance driven, but, you know, if they deny another day in the hospital, you know, your case manager, social worker that's assigned to you can appeal that.
Correct.
So you might get another 24 hours.
And that's
you
another
know?
word that people aren't
Yeah.
aware
Right,
of.
right.
And you can
So,
appeal if your
yes.
insurance stops
Yes,
paying for
right.
your
And then
rehab, but you're not
Right.
ready to go
Yes.
home yet.
Right.
Yes.
So there
Because
are
people aren't realize that unless
No.
you're
A
in the
little bit of
industry.
pushback, I mean, you can't push back everything, you
No.
know, and if there's
Fair.
no bed in
But
such
if
and
it
such a
gives you a
facility,
couple of extra,
there's no bed, but.
an extra day or two or
Right.
whatever.
And then sometimes the
Yes.
insurance make the wrong choice, and then you know what, when they appeal, we show all the documentation of why she needs to be there,
Right.
why he needs to be there, and that's
Right.
it.
And they say,
Yes.
okay,
Yeah.
we'll give you another
Correct.
5
Another
days of
week.
rehab,
Correct.
right,
And
which
that's
is
what
what
they
they
need
needed.
to get home. Be
Right,
safe.
exactly,
Yeah.
exactly, so,
Yeah.
great. Any other questions that you have for us, Harry?
No, we're gonna be wrapping it up. We're getting
wow.
close to the end.
Right.
How fast an
Time
hour ago?
I know.
Now, do you feel like you're an expert in all of this?
His son's a
Well,
physician.
we're doing it.
Yeah, but you know what? The nurses and physicians are the worst ones.
Yes, that is
I've been
true.
doing this for over 30 years.
He also has his book together.
Yeah.
Yes.
His healthcare
Yes,
proxy.
we're
He's
impressed.
he's in
He's
good
got
shape.
Funeral. He's got it all.
Yeah, he's even got his burial done.
Oh, yeah. I got a call from the insurance company last night. I have Blue Cross Blue Shield in North Carolina. And a nurse called me and asked me, oh, how you doing and how, and, yeah, have you got a proxy? I said, yes, I already did. Oh, that's good. You did, because they were gonna send me all the paperwork.
Yeah,
Yeah,
healthcare
no,
proxies,
you're all set.
most
Yeah.
papers are so important. You
Yeah.
know, we have the vial of life, you know, anybody should have that information on the refrigerator, so if
Yes,
something
definitely.
happens, when the EMTs come in, they look at that refrigerator immediately, if they see the vial of life, they know, right?
Yep.
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 Very important.
It's also nice to keep it so that your scripts are there and everything is there. So if something happens, your family doesn't have to panic going
Right.
through a medicine cabinet. What does she take? What
Right.
doesn't she? The doctor can help
Yeah,
you with
have it all
those.
right.
My
right.
chart
Senior
is
centers
very
can give you
helpful,
those,
access
and
to
you can
my
fill them
chart,
out.
yeah,
Yes.
within the hospitals.
I
We
know
pull
it.
up everything.
Oh,
you
true.
know.
Yeah, that's true.
Mm,
Yeah, my
So.
chart is.
yeah.
I was in a hospital in August for 3 days. In Milford. Fantastic. I would like to stay.
He loved the food.
I was just gonna
Food
say
was
that.
excellent.
It was like
Food
a
was
spa,
excellent.
a spa
menu.
weekend, you
You get a
know?
menu just like in a restaurant.
Well, you're doing good now, that's important, so you go
Yeah.
back to your baseline, right?
Well, I found the problem and
Yeah,
And be
good.
good.
they straightened it out right away.
Excellent.
I couldn't go more than 3 days anyway because Medicare won't pay.
But if you had to go to rehab, you had your 3 nights, right?
Yeah,
you
three
do
midnights.
days,
So
right.
Lee could help you.
It's
Come on,
nice to
right?
hear someone say that they had a good experience.
I know.
That really
You know,
is.
it really
Yeah.
is.
It sounded
I'm
like it was a
over you.
vacation. I was like, oh, this is
Well,
lovely.
that's
I'm happy for you.
Best food. I didn't have to do anything for myself.
I think he
Again,
finally
right?
rested
I
because
think
he's so busy
I
all the
know.
time.
I think
I
we're
even had
blessed
a-
where we live, we
I had
have
a
so many
single room.
options.
I had a private room
Yeah.
Can't ask for
There you
better.
go. Can't
right
get any
across
better.
from the
I
nurse's
said, I think
station.
someone
so
might have made a
Oh,
phone.
wow.
You're right
That's
there.
Maybe a
if I need
physician he
anything,
knows.
it's right there, right
You just
there.
shout.
Or maybe they were like, isn't
Oh,
he the guy who has that cable TV
Yes,
show?
exactly.
We better be really good to him. Because word of mouth can really be a hard
Well, we're
thing.
glad that you're better and you're here to do the show.
There was an esophageal problem.
Ooh,
I had to go in by ambulance at 11 o'clock at night.
Scary.
yeah, very scary.
Yeah.
And that was the only problem. I was in the emergency room till about almost 2 or 3 o'clock in the morning because they had no bed available.
So you
Yeah.
actually were lucky that you were only there for that many hours.
Yeah,
It's
Yeah.
true.
It's
They were good.
crazy how long.
And then
Stay
got a
there.
private room.
Correct.
Yeah.
Some people
Well-
stay there.
They treated me good, and the
Yeah.
ambulance service in this town is phenomenal.
Yes.
Yes, it is.
Oh, our ENTs are amazing.
Yeah.
They are, oh
Minute,
God,
so.
they're the workhorse too.
They
are.
They're
They
just
sure are.
unbelievable.
Super job.
Yeah.
And that's a tough job. They on 24 hours.
Right, they do the shifts, yeah, didn't realize, yeah. And
That's
you
a
got
very
your
difficult-
paramedics and, yeah.
Healthcare's a rough ride, I think, pretty much top to bottom.
Yeah,
It's-
exactly.
And they never know what they're
It's
walking
not getting
into.
better.
No.
No,
Yeah.
no.
Neither
Sometimes-
do your staff.
No.
Yes.
Or yours.
No,
Right?
you don't.
You
You
don't.
don't. You really don't. And like I
Yeah.
said, the problems do happen at 11 o'clock at night or 3 in the morning.
Right.
You know, it's
never
not
at 9 in the morning,
ever on
yeah.
your. You know, I'd like this to happen
Right,
at
you
9
don't-
o'clock when I'm
Yeah.
not.
Yeah, you don't pick the time to get sick.
No.
Well, we gotta go.
Yes.
Okay. Well, thank you so
Thank
much.
you
Thank
so
you.
much
Thank
for
you so
having us.
much.
Thank
Next
you.
week,
Good to
I'm
see you
gonna
again,
have
Kelly.
the youth commission
Give me a
is gonna
call
be
and
here,
we'll
and
put
we'll
something
talk
together.
about
Definitely.
what's going on with them.
Yes.